program across centers, across institutions, and on different modalities. If I say modalities, I mean different vendors, SG, Siemens, United Imaging, and so on and so forth. So I'll be sharing my ideas I have gathered over the years, both in Nigeria and in Canada, and try as much as possible to make an average of the two and give you a perspective of what you need to put in place to basically assist you in the design of your program. Yeah, that being said, I'll be speaking based on this outline, starting from the introduction down to the problems that are associated with setting up a CMR program in your center, down to the sequences that are necessary. And then I'll throw a little bit of idea on both contrast and non-contrast CMR, which of them is basically possible in your center. I know when Professor Friday comes in, maybe getting to the tail end of this program, he's going to talk well and loudly about the non-contrast CMR acquisition. But from my end, I'll just give you a baseline and then open your heart to some of these imaging sequence we could set up on your scanner that will help you acquire images that basically you necessarily do not need you do not need a contrast for every CT, for every MRI imaging that is being done. Okay, that being said, just to start up with, I'll be throwing a little bit of light to some of the work or one of the work that has been done in 2022 by Professor Oduna, myself, and the team on the needs assessment study that was conducted using Nigeria as a point of call. Now, in 2022, we are looking at, okay, how do we set up or decentralize the practice of MRI in Africa as a whole? And then if you want to go as wide as trying to decentralize the practice of MRI in Africa, you need to start from home. And then we did a little bit of study, not really a little bit, a lot of studies on the needs assessments, that some of the things you need to put in place in trying as much as possible to achieve your aim in decentralizing the practice of MRI. One thing we did was to coin out an acronym from the word MRI, and we saw that basically in Africa, using Nigeria as a point of call, you have massive population. This massive population, they are really resilient, and then they are intellectually rich. But then you can be resilient to an extent and not really achieve what you were intended to achieve. And in this work, we basically looked at what are the numbers of MRI in Africa or Nigeria as a point of call. What are the numbers of research that has been done when you look at, okay, in the African continent and other LMICs, and when you compare them to high-income countries out there, or the Western part, Western world, as it is being said, we saw that one, there has been tremendous or gradual access to electricity across Africa and across Nigeria, though it is not where we intend it to be. But there has been this access to electricity has seen a gradual improvement over the years. And because there is this access to electricity, we now begin to see that, okay, organizations, governments, private institutions are now beginning to, okay, bring in MRI to, to aid radiologists, doctors, and so on and so forth in how they are able to, set up their system to diagnose more, to characterize more, and so on and so forth. So this access to electricity we saw engineered an increase in the access to MRI also. And because we saw that, okay, there is this access to MRI that is coming up, we now, okay, thought about it. Why not we also include some of the advanced studies that are basically out of reach for say, that are basically out of reach for the African continent, for the other LMICs, such as the Southeast Asia and South America part of the world. But then, when you also compare some of the things we do in Africa and other LMICs and other advanced countries in the world, you realize that we are still lagging behind. And when I say we are lagging behind in the number of research we do. We are lagging behind in the number of MRI scanner per 100,000 population. We are lagging behind in the number of advanced studies that you could basically, when you travel to the West, these studies are at your beck and call. You can basically put a request to these studies, and then you will get them done. But then we are not seeing them happening over here in Africa, and that is where camera MRI Africa has been working so much to try as much as possible to, give this access to MRI to the underserved population. Now, another thing we saw in this research that was done in 2022 is that when you compare the number of research that is being published from across Africa, Southeast Asia, South America, to other parts of the world, such as Europe, um, North America, and so on, you will realize that Africa as a whole produces less than just approximately about 0.5% of the total MRI publication over a period of a decade. We produce just about 0.5 of the total MRI publication you see out there. And then when you put Africa in context, you will realize that Nigeria stands out, North Africa stands out. In fact, going to North Africa, Morocco, Morocco, Egypt, and so on, Tunisia, they stand out in the number of publications. You look at South America, they also stand out, though they might not be where they want to be, but they do stand out. And then you will realize that a bulk of the continent is doing, maybe they do not know how to publish, but a bulk of the continent are not giving out these data that could basically help research, compare research from this part of the world to that part of the world, and then expand our understanding and help science as a whole. This is a problem that we thought, okay, could be addressed. And then you also look at the number of studies that are done across board, say from the musculoskeletal system to the lung and the heart and so on and so forth. You will realize that cardiac MRI, for one, is still on the lower tongue on the lower spectrum on the lower spectrum. And then when you also look at the countries that are basically doing quite a little bit of study, Nigeria and South Africa stands out, which is great. And then you basically hear me saying Nigeria, Nigeria, Nigeria. It's not like I'm being biased, but I'm using it as a yardstick in comparison to other African countries that are out there. Now, I also believe that the radiologists that will be coming over the period of these 8 weeks, they will be talking about different aspects of CMR. Now, because they'll be talking about different aspects of CMR, my homework today is to basically help you in having to open your mind on some of these modalities or some of the functionalities that needs to be put in place to help you set up a CMR protocol in your center. Now, I wouldn't be able to do that without also giving a little bit of background on some of the importance of, cardiac MRI, because you might be hearing cardiac MRI, cardiac MRI, cardiac MRI. Initially, when I started, I used to see cardiac MRI as the El Dorado of imaging. Most difficult, most advanced, anything. In fact, when they install systems for you, they technically might want to shy away from me. So I feel, maybe it's too difficult. That's why they. But then, as I grew in my profession, I realized that I see why it is basically the El Dorado. I'm not saying other imaging are not that important, but I'm just saying I see why people place a lot of emphasis on it, especially in the West, when you compare it to the global South. Now, cardiac MRI is basically the gold standard when you are looking at imaging the heart. And we know that the heart, just like the brain, is one of the, I don't want to say the most important, but one of the important organs in the body. Now, cardiac MRI does quite a number for us, which you all know. It helps us in functional assessment of the heart, whereby you could basically assess the ejection fraction of blood flow in the heart. You're also looking at perfusion imaging. When you say perfusion, you are basically looking at either you are injecting contrast to assess the muscles of the heart or the anatomy of the heart. or you are also looking at having to challenge the heart. Maybe you give some instruction to challenge the heart, and then you can assess the perfusion thereafter. Cardiac MRI can basically help you do that. Cardiac MRI can also help you in assessing viability of different tissues of the heart. And then most importantly, you can study the morphology of the heart, the various chambers, the various waves, to see the connection between one chamber of the heart to the other. So this is what it can offer you if you are able to set it up on your system. If you're able to do this on your system, it can basically help you help your radiologist, your cardiologist, and even the referring doctor make an informed decision in the total well-being of a patient. Now, like I said earlier on, it is not like we are not looking at the African continent or the other LMICs as a whole, but we are using Nigeria as a point of contact. For Nigeria as a whole, or for Nigeria as, for example, right from the onset of the installation of the first MRI in Nigeria down to where we are today, we are seeing steady improvements. Steady improvement in imaging small body parts, steady improvement in imaging blood vessels using MRI, steady improvement in imaging other specialized organs in the body, and so on and so forth. But then we are working since 2023. The team at CMR MRI Africa and my able radiologist, Dr. Anosike, Dr. Ahmed, Dr. Tosin Inolo, have been doing, Dr. Tosin Emajekodumi has been doing a lot of work to see that beyond just imaging other parts, other parts of the body, such as the brain, the small part, musculoskeletal, and so on and so forth. We want to be able to, also image the heart, and not just imaging the heart. We should be able to do it as much as effective as it should be. In that, when you get the images here in Nigeria or other part of Africa, it should be, when you compare it to other imaging that are acquired out there, the difference in acquisition, the difference in subjective analysis, the difference in objective analysis shouldn't be that much. You should be able to say, yes, your reports are comparable to what is obtainable out there. And that is basically what we are looking at doing for CMR as you go through this training program. Now, one problem we have when it comes to CMR is the access problem. Access problem. I'm not talking about access to MRI. I'm just talking about access to cardiac MRI as a whole. Now, the first thing is the cost of setting up an MRI machine, and then adding the cost of setting up the capability to do a cardiac MRI is a lot. First of all, if vendors are to set up MRI system for you, this costs about $1 to $3 million, depending on location and depending on country. But then if they are able to add extra capability so that you are able to acquire cardiac images, and not just the basic cardiac images, but the advanced cardiac images also, this cost might see a steady increase. But then we realize that some centers have already set up their CMR, like them. Some centers across board have been able to install their MRI machine. So they are now looking for ways of trying as much as possible to optimize what they have at the moment to be able to do some CMR examination. When I say CMR examination, I mean cardiac MRI examination. So cost is one of the limiting factor when it comes to, having to have an MRI machine and also install extra capability of being able to carry out a cardiac MRI imaging. Now, number two is personnel. You have a lot of personnel across board doing cardiac MRI, doing MRI as a whole, which is fine. But you need extra training to be able to carry out cardiac MRI. And this training you will not get just over the period of 1 year, 6 months to 1 year. You have to, while you are getting the theoretical knowledge, you also need clinical experience to be able to carry out cardiac MRI. So personnel shortage is one of the access problem we have when it comes to CMR setup. Then number two, contrast. One of the mindset a lot of persons have is if you are doing a cardiac MRI, should you basically need contrast investigation to achieve your aim across board. But then, as you grow, you get to understand more, and which is fine. I now realize that it is not necessary that it is every cardiac MRI investigation that needs a contrast imaging, and then people are basically exploring ways out there to try as much as possible to reduce the use of contrast imaging, because basically gadolinium that is basically used in contrast assessment assessment is expensive. It might not be expensive for them who are in the western part of the world, but when you come to the LMICs across Southeast Asia, South America, and Africa, you have to put into context the price of gadolinium, so that you could also, because if the price of gadolinium is astronomically high, it is going to basically affect the price of CMR in your center. And if the price of gadolinium is not too high, maybe average or lower, it is going to affect the price of CMR investigation across the board. Some countries basically have to pay out of pocket. And if you are paying out of pocket, that puts extra price on you and extra price on your well-being. And then the second to the last is the awareness. There's little or no awareness, and that is basically in this across board, in the primary health center, in the secondary health center, in the tertiary health center. We are trying as much as possible to increase awareness so that radiologists could make this, the referring doctors could make requests for CMR. The attending medical radiation technologists would know what is required, and then there's also radiologists on board or cardiologists on board to give you an optimal report that will help the doctor make a crucial diagnosis, as the case may be. And then protocol is also a problem across board. I have been with different centers over the years, and I see that setting up protocols for cardiac MRI is basically a problem that needs to be addressed. And I hope that after today's lecture, you are able to have an idea on what you should do. When you see your scanner tomorrow, you're able to check through your scanner and be able to say, okay, this is what I want to do. Am I able to do a cardiac MRI on this system or not? Now, that being said, we had a discussion with Siemens in 2023, and they used Nigeria as a point of call, and where they said there is increasing need for CMR in Nigeria, because they have seen a steady rise across board for heart failure, stroke, and other diseases. And when you have stroke and heart failure going hand in hand, you know that, you need imaging that are beyond just brain imaging or other body imaging. You need imaging that covers both the heart and the brain almost synchronously or at different times. Now, the key question that would be in your heart, you might be thinking, can my existing MRI scanner do cardiac imaging? The question is either a yes or no. Now, I know that most MRI systems that are installed across Africa and Nigeria are basically the 1.5 and 3T. Though we know that there are upcoming low-field MRI now, but then majority of the scanner, just like we saw in the camera MRI needs assessment study, is 1.5 and 3T, And I believe that when you look through your system, you may have the capability to do cardiac MRI. You may. I leave it at that for now. Number two, do I need contrast gadolinium for every cardiac MRI? The simple answer is no. Now, Professor Friedrich will be coming in later on to discuss on what is known as oxygen-sensitive cardiac MRI. Now, oxygen-sensitive cardiac MRI is similar to what you call the stress cardiac MRI, or when you put it in a very simpler knowledge, where basically give the patient adenosine and so on, and then you stress the heart, and then you can basically run the scan during the period. But that is for that. That's just to let you know that you basically do not need contrast for every cardiac MRI process that is to be done. Now, what staff? You need specialized trained medical radiation technologists, cardiologists, and really, because eventually, after you acquire these images, you should be able to figure out that, sorry, not like limiting the radiology, but some radiologists are specially trained or cardiologists are specially trained to report cardiac MRI. And then what are the minimum protocol to offer real-time clinical values? Now, I believe when you look at your scanner, maybe you get back to your scanner tomorrow, or even you're on your scanner now, you should be able to go to some section of your scanner and look out to see that you have what is known as the localizer. And then you should also have the sequence that could help you understand the morphology of the heart. And then you should be able to have some sign functional sequences. The sign sequences basically helps you to see the flow, the beating of the heart, if I want to use that word as a layman, in real time. Now, I also understand that maybe during installation, some vendors might lock up maybe some advanced sequences in your cardiac session on your scanner. But then one good thing is if you are able to draw their attention to it, or even if you are contemplating installing a new MRI in your center, try as much as possible to let them know that we want to be able to carry out cardiac MRI in our center. And these are some of the sequences. We want sequences that are able to help us understand morphology. We want sequences that are able to help us carry out functional assessment of the heart. And then we also want sequences that are able to help us carry out, perfusion studies for the heart. If you tell them this, they already know. And then when they are installing your system, they are able to put in those functional capabilities into your system. It might not take a lot because at that point, they are not already, they are still contemplating to try as much as possible to sell this system to you. So put that into consideration. And then how do I justify this to my hospital? Fine. Like I said earlier on, using the word El Dorado, I said CMR is like the El Dorado of imaging. You should let them know that if we have this on our scanner, we are able to do some advanced study, and it will help us understand the functions of the heart as it relates to other parts of the body very well. Apart from the very fact that it uses less radiation, and then it replaces the need for multiple investigation, and then it might basically help in aligning with growing cardiovascular disease burden in Nigeria. So you imagine, for instance, we know we have, let me say, three major ethnic groups in Nigeria. For instance, I know some other persons are from other countries across the world. I'm using my country as a point of contact. Now, for each geopolitical region, and you only have one MRI system that is able to do cardiac MRI alone. And remember, as far back as 2022, when we did the camera needs assessment study, we only had one MRI machine that is able to do cardiac MRI. So you tell me, if we had more systems that have the capability to do, cardiac MRI across board, you will realize that the number of data we could acquire from this system that could help policymakers make informed decisions will be high. But then if the access to cardiac MRI is very low, policymakers might not necessarily know what they might do to justify the growing burden of cardiovascular disease across board. Now, how does LMIC, that's low middle income countries, fit into the global CMR movement? We want to see an uptick or an upkick, as the case may be, in access to cardiac MRI across board. And though we have been working over the years to see that we do this across board in Nigeria, across board in Africa, across board in Southeast Asia, South America, and so on, we want to see high access to CMR imaging, We want to see high number of research that are basically focused on CMR done. This will help us understand disease burden, not only cardiovascular disease, but disease burden across board. And then we want to also try as much as possible to decentralize the practice of CMR across board. I will show you some of the work we have been doing over time that could help you understanding and see some of the effort we put into try as much as possible to see that the underserved regions of the world are having access to cardiac MRI imaging. Okay, so what you likely already have and what you need are two questions that might be on your mind. Now, what do you have? You have 1.5 MRI, for instance, and I also believe you have general body coil, maybe the 32 channel. You have the general body coil, which is fine. I also believe that the one you use for your abdomen or the one you use for your chest imaging, if you want to do that. And then I also believe, I don't want to be totally sure for this one, that you have what is called the ECG monitoring equipment. Recent machines or recent systems that have been under installation for the past say 5 years, they most likely are going to come with ECG monitor. I'm going to show you what the ECG monitoring is in a moment. And then you need trained MRI staff, basically trained to do other parts of the body, but specifically for CMR imaging. And I'll tell you a joke here. When I basically left Nigeria, I thought I could do CMR imaging. But then by the time I got to Canada and I realized that, oh, let me go tell them I could do CMR imaging, show them some of my skill. And then I got there and I realized, oh my God, these people are doing far beyond what I thought I knew. I had to sit down and learn and totally relearn. And that was where I met Professor Friedrich, who reoriented me about cardiac imaging. And then I felt like, okay, if I have this knowledge, we could basically help those that are back home in Africa, back home in Southeast Asia to get more. So I believe you have trained MRI staff. You don't have dedicated CMR staff. You might need one, and then you basically have the PACS to reporting system. So I believe you have this one. And then what you most likely would need to add to some of this you have now is a dedicated cardiac coil. If you don't have the dedicated cardiac coil, you might basically still work with your general body coil. It's fine. We can still work with your general body coil if you don't have the dedicated cardiac coil. Now, the dedicated cardiac coil has an anterior and posterior array coil. I only saw this with United Imaging, their dedicated cardiac coil. I believe Siemens is also working on having to get a dedicated cardiac coil. But if you don't have it, don't fret for this. We could basically use your general body coil. Now you need CMR sequence packages. I'll be very. Oh, thank you, Doc. So Siemens has dedicated cardiac coil, which is fantastic. Also, now you need CMR sequence packages. Now, some of these sequences are open on your system. You just need to sit down and open it and see what you can do with it. I believe every system also gives you the access to basic CMR sequences. Every system gives you access to basic CMR sequences like the localizer, like the sign sequence, and then the sphere imaging sequences. You have that. You might not have access depending to the advanced, they might lock it up. So you need to, if you know you want to do some advanced studies, maybe perfusion, or you also want to do flow imaging for the heart, you will need to speak with your vendor to give you access to this. And then you might need CMR training for your MRTs. Yeah. Oh, well said. You can build one. I think that's easy to say. Was difficult. You know, she has a better faith than me. CMR training. Now we did something in 2023. Yeah, that was our. We trained MRI tech across board, and Nigeria, Africa was heavily represented in that training. It was fantastic to see that After that training, we had a lot of interest from radiologists, from cardiologists, and we also had interest from Professor Friedrich, which is great. Actually, it is great. And also, reporting cardiologists is needed. Like I said earlier on, not all radiologists can read a cardiac MRI. You need specialized. This is easy as long as this you can get fixed as soon as possible. This training you can get fixed as soon as possible. I think of everything I've written here, the CMR sequence is what you should pay a little bit of concentration to. Maybe you just need to go back to your system and look at what you can do with your system, and the rest can be sorted out. Now, cardiac MRI is just like cardiac CT. And those of you, I know majority of centers do those cardiac CT. There are two types of imaging of the heart, which you know, and you have the retrospective and the prospective imaging. Retrospective, you acquire the images and then you go back and begin to get the best of the best amongst all of the scannings you have done per time. And then the prospective, you acquire like as the word goes prospectively, you see the image, you get the good one, you see the image, you get the system scans according to the heartbeat and so on and so forth. Now, I'm not going to dwell too much on this, but if there is one thing I think you need for let me go back to this. I believe you have this ECG monitoring goes hand in hand with your getting for your cardiac MRI, which is good. So if you are able to get the ECG getting on your system, or if you have access to ECG gator on your system, don't worry about the prospective or the retrospective. We are only having to see that during scanning, you don't take a lot of time. Should in case the patient have an unusual heart rate, you are able to either revert to either retrospective scanning or prospective scanning, depending on what the case may be. Now, the preparation for cardiac MRI patients is basically the same across board. The same preparation you give to, the normal MRI patient. The only difference for this is you connect an ECG. Like I said, it's most likely similar to your CT cardiac, in which case you need to connect an ECG monitor that links the patient to the system. An ECG monitor that links basically the patient to the system. So you need to look at your system. Do you have an ECG monitor and what to do with it? That what to do with it is the training aspect. And we think we can help you set it up if you have access to that. Now, this is what I'm saying. Every system should have the capability to do this. It might look very casual to the eyes, but then this system ECG gator is connected directly to the patient from what you can see here, and then also connected to the system on the back end. And then when you are scanning, you are able to monitor the heart rates. You are able to know if you should go ahead and scan. You are able to know when the patient is not breathing. You are able to know if the patient is breathing, and then you know when to acquire your image per se. And I'm saying this because because the sequences that are used for cardiac imaging are basically some of them are the GRE sequence that are fast imaging sequences. You are able to tell the patient to hold their breath for a while, and then you can monitor the heart rate. You can monitor the breath of the patient. At which point the patient is not holding their breath, you're able to call the attention of the patient to that and say, oh, come on, you need to do better in holding your breath and so on and so forth. So like I said, you need to check your system if you have the capability to do ECG monitoring on your system. Now, like I said earlier on, again, that across board, we have been going across Africa to help centers set up their MRI cardiac. Yeah, we have been doing that. One center that has been at the forefront of cardiac imaging is Urake Multi-Specialist Hospital in Nigeria. They started it. I believe they started it. And now we are now decentralizing. As of today, we have about 4 or 5 centers across Nigeria that could single-handedly do cardiac MRI. There might be more than, fine. But then we also have regional hospitals doing cardiac MRI, we have the Redeemer's Health Village. The Redeemer's Health Village, for one, is interesting. And Regions Hospital also is interesting. And that is where I want you as the radiologist to come on board, because the radiologists, the cardiologists are like policymakers. You have access to the management of your hospital. And when you know that they want to install maybe an MRI machine, you should be able to make recommendations for them on some of the functionalities you want in your system. When Redeemer's Hospital were to set up their imaging, they called Dr. Akintomide of General Hospital, and Dr. Akintomide reached out to me. And one thing I told him is, Redeem as a whole is, is a standard organization, and any system that is to be installed in that place should have some of these capabilities. And then I listed it to them. When Region was to set up their own system also, they reached out to Dr. Anosike and then Dr. Oduna. They made recommendation for them, and then it became easier for them to, implement cardiac imaging on their system. They don't need to go back running after the vendors to help them implement, cardiac imaging. Should in case this system have already made, I believe that is also what Urake did. They were able to get first-hand information on how to get these sequences on the scanner over time. So that, and then that basically helped them to be like the forerunner of cardiac imaging in the country. Other institutions that we visited across, myself, my supervisor, with the help of Dr. Anosike and so on, also is University of Maiduguri Teaching Hospitals. And then we've also visited Yobe State University and then LASUT. These hospitals are reassessing their capability to carry out cardiac MRI imaging. Like I use the word reassessing. I use it conservatively because we have gone to these hospitals and we see that they could do more than what they currently do. And I believe your center also should be able to do more than what you already currently do. Of all the systems I have used across board, United Imaging, Siemens, Philips, Viomedics, as the case may be, this MRI system I don't want to say what, it's one of the best I have seen, not in terms of the hardware, but in terms of the software. I believe maybe the management got an hint of, having to tell Siemens that we need this, maybe yes or no, fine and good, but the software is the upgraded version, and that is where you need consultation as a whole, especially for radiologists, policymakers that are to help your hospitals in installing MRI. You should reach out, inquire, what do we need on this system? Yobe State is basically doing that at the moment. University of Maiduguri is doing that at the moment. They are reaching out, making inquiry on having to understand what are the necessities that should be on their system before they let these vendors go. And then you are able to make recommendations, and these are sorted out before even you start scanning on your machine. Okay. Just to give you an overview of some of the sequences that are necessary for cardiac imaging, the very popular one is the BSSFP sequences that are fantastic when it comes to cardiac function, volumes, and wall motion assessment. They are very sensitive to blood flow. So I think they are very sensitive to blood flow, and they are very the time of acquisition is just a fraction of a second. So you are able to tell this patient to basically hold their breath for maybe 10 seconds or 5 seconds or 15 seconds or 40 seconds, as the case may be. BSSLP is your go-to. So I believe every system has the capability. So if you go back to your scanner, you're able to open up your scanner and see that majority of the sequences you have in your scanner are BSSFP originated. Then you also have scanners that have the capability to carry out bright blood imaging or dark blood imaging. These two goes hand in hand. They also are linked to BSSFP that is basically used in sign imaging. But then all of them, they have their limitation. Not a lot of limitation as the case may be, except when you are using a 3T MRI, you get to see some of this limitation. But I believe you have 1.5 system or lesser or lower field MRI. This limitation shouldn't be so prominent when you are running your CMR protocol on your scanner. And then systems ability to the sequence ability to help us in viability study. Majority of these are basically in the post-contrast phase where you have the inversion recovery sequences. You also have this. I believe almost every system has it. We're in LASUT recently, and LASUT are doing a lot of work in terms of having to implement cardiac imaging on their scanner. And when they check their system, when we check their system, we realize, oh, they have PSSFP, they have the bright and dark blood sequence. They also have the inversion recovery, which is fine. All they need to do is to basically speak with their supplier if they can have access to other advanced studies like I will mention later on. And then you also need a phase count. This is an advanced sequence. I don't want to undermine your system, but I believe you might need the help of your vendor supplier to give you access to this flow quantification sequence. Good thing is regions have a flow quantification sequence. I think I worked with it once, which is fantastic. I also believe Redeemer Health Village have it, and I believe your scanners can be upgraded to also do face contrast imaging, which is basically called the flow quantification. But then all I'm saying is this. If you are at the verge of installing your sequence, or you already installed your sequence and you have the opportunity to influence the adjustment of sequences on your scanner, and you want to have the capability to do CMR, put these sequences in view. You should be able to do the basic BSSFP sequence that helps in sign images to flow quantification or whole heart imaging. If you want to be benevolent enough to yourself, you can also request for what is known as tagging. I only saw tagging imaging once in my life when I worked with the Professor Friedrich group, and it was fantastic. It helps you understand the viability of the heart. It helps you understand the ability of the muscles to contract and retract. I actually kept an image for it here. I will show you later on. All right, so everything I have said, you should be able to do the basic imaging, the basic sequence. You should be able to also do, these are basic sequences. I believe the inversion recovery is in between basic and advanced. But I also know that if you have the capability to do cardiac imaging, you should have the capability to do post-guard imaging. Then the phase contrast imaging, this is it. You should be able to see, the flow quantification. When we say flow, the movement of blood across the large vessels of the heart. You should be able to do that. And these are benefits. If you give a radiologist this imaging to view for you at different angles, at different points, at different subjective analysis, they are able to give you a well structured report that will help the referring doctor in making an informed decision. Now, for those radiologists that might, for radiologists or intending radiologists, or I believe techs across board should have techs across board have basic knowledge of some of the axes that we look at when it comes to imaging of the heart. Now, because the heart is in an oblique position, so you might not necessarily be able to do an AP and lateral of the heart to get a good view of various chambers of the heart. So you need various imaging planes that would help you in understanding the different planes of the heart, the different vessels of the heart, and so forth. So one of those is the axial thorax that helps the reporting radiologist to make an informed report on the overview of the thorax as a whole. Then you have the long axis view, which is basically a two-chamber, helps you to see the left ventricle and the right ventricle. And then you also have the fourth chamber, basically called the horizontal long axis. You are able to see the atrium and the ventricles and the veins connecting them. And you are able to also assess the muscles in between different chambers of the heart. And then you are also able to see the left ventricular outflow tract. You are able to see that also. as the left ventricle pushes blood out. This can be acquired in real time, and you can also do a flow imaging for this, depending on what you are targeting. And then most importantly, as you have seen in a lot of journals, is the ability to be able to see the muscles of the heart, and then you're able to calculate ejection fraction, you're able to calculate perfusion around the muscles of the eye, most especially the left ventricle, and so on and so forth. Okay, I have said this earlier on, not every cardiac MRI needs gadolinium, and I believe Dr. Friedrich will basically do a lot of talk for you on OSCMR. We did this in 2023. And we published a paper on it. I think the paper is here. Yeah, we published a paper on this. Myself, Katrina, Dr. Oduna, Dr. Anosike, Professor Friedrich, and we're able to decentralize the imaging, we're able to decentralize the duration of time it takes. Before we do cardiac MRI for about 1.5 hours, but we decentralized it and made it targeted scans for some cases 45 minutes, depending congenital disease, contracted cardiomyopathy 40 minutes, and so on and so forth. We decentralized the number of time it takes to acquire some of this imaging, and then we also implemented the first oxygen sensitive method, like I said earlier on in my. Yeah, I said not every CMR needs gadolinium, which is fine. Now, we're able to, implement the first oxygen sense.
Sorry, Harrison, you're muted. You
Oh,
you sort of popped out. No, I can hear you now. So go ahead, sir.
okay,
There may
good.
have been
So,
a little glitch there. So can you
oh,
just rewind?
okay, so like I said, we did this oxygen sensitive method in collaboration with Professor Friedrich Group at the McGill University Health Center, which was fantastic. I want to see more of this being implemented across board in Nigeria and Africa and other LMICs. Fine. Now, we also want to see the implementation of advanced sequences. These images you see here are collaboration between Camera MRI Africa and then the Siemens Global in the work we did in 2023, which is fantastic. And they encouraged us we could do this in Nigeria, and perfectly we did this. We were able to acquire some of the mappings in Nigeria also, and across centers, across board. These are images, especially the upper images you see here. These are images we acquired across the board in Nigeria. The mappings, the flow imaging, the 3D reconstruction imaging, and then we also were able to acquire some morphological images. Now, I mentioned about the tagging, that you are able to see the elasticity of the heart muscles. This I saw in real time at, um, at the McGill University Health Center. And I feel one of my goals is to see that we are able to implement this in scanners across the board, say in Nigeria or other health. And it's not difficult. You only need the sequence. And this you can acquire in less than 5 minutes. And it helps the radiologist, the cardiologist make a well-detailed report that would help the referring doctor make informed decision. You understand? So if we are able to acquire this imaging, I displayed up here, especially the mapping, the T1, T2 mapping, and then the ion content across the heart, we should be able to do tagging. So it's my next target to see that we are able to do tagging sequence. Not difficult. If the license is there, fine and good, fantastic. And then I'm almost done. I think one thing I need to also address is artifacts. Artifact, fantastic. Artifacts. There are various kind of artifacts across when you are imaging the heart. The artifact that runs streak, that runs like a streak in the smooth muscles of the heart when you are imaging, especially in the short axis sequence. There are artifacts that arises due to field in inhomogeneity, especially when you are working with an higher field strength such as 30 and 70. There are artifacts that arises from incorrectly placing the coils over and above the heart. Yeah. So some of these artifacts needs to be put in place, and that is where you also need collaboration in setting up your system. When you are able to set it up, you also need training for your techs so that when they acquire these images, the number of artifacts is drastically reduced to the barest minimum, so that the images that are acquired over here is comparable to the images that are acquired in the West. And one paper that did a lot of work in helping us understand that if artifact can be as small as banding artifacts, let me see if I can find one. Yeah, see my cursor. As small as it is, in some not well-informed center, I've acquired a very beautiful image, they pass this because they are able to see the outflow tracts of the left ventricles, they pass this. But however, in the West, you are able to, by the time you are scrolling through your image and you see a small artifact that is either casting from the stomach or a small artifact as this, you ought to repeat that image because it will disrupt or it might not help the reporting radiologist in making an informed decision. So that's where training comes into play. Apart from trying as much as possible to put the hardware in place and the software in place, you also need to put training of personnel into place. And I believe Dr. Anosike and Professor Oduna could do that for you in trying as much as possible that you get it sorted out. Now, if you want to build your CMR program, equipment audit your equipment, your staff training, like I said earlier on, then you also need to know the non-contract protocols you have. And then you also need to know the policies surrounding cardiac MRI in your country. And then you can run a supervised pilot cases. Supervised pilot cases, you have a lot of experienced hands such as Dr. Oduna and Professor Anosike, or even Professor Friedrich, if you have access to him. And then you can basically expand into gadolinium capability. Then you can also decentralize your sequence to disease specificity. So you can design a sequence for, say, cardiomyopathies, valvular disease, and then congenital. I know I did a lot of congenital imaging while I was in Nigeria with Neuracare. We did a lot of, especially for children. It helps them make informed decision. And then try as much as possible to make sure you have the mappings included in your cardiac imaging sequence. It's just like for reporting radiologists for breast, and you are not including subtraction imaging for them. You are basically doing a lot of harm and good. So try as much as possible to make sure that mappings is included in your imaging, and then quality, and then you can basically train others. Pass the knowledge across. We did a work in 2023 where we trained some participants across board, Nigeria, Ghana, Nepal, Chile, and Kenya, and so on and so forth. Key takeaway for you. Your existing scanner can be activated for cardiac MRI. You don't need to buy a new MRI sequence. Get that in view. Non-contrast protocols can also be, we did it for Urec, and I believe we can do it for your scanner. We can also implement non-contrast OSCMR protocol for your scanner, and then check your ECG gating. If you have the capability, there are two types of ECG gating, the one you put in the chest, and then you have the peripheral ECG gator. Should in case the ECG gating for the chest is not basically giving you what you want, you can basically use the peripheral ECG gator. And then, from my hand, Nigeria has the highest CMR in the world in Africa. And then we have been able to decentralize CMR imaging, which is fantastic. And I believe other African countries can basically come on board to try as much as possible to do this also. And then you can start with OSCMR, non-contrast, you can build confidence, then you can add contrast capability, and so on and so forth. And if your center is maybe a tertiary health institution, you can basically add, you need to try as much as possible to decentralize your sequence so that since you have varying clinical indication, you design each indication to suit what the radiologist or the doctors want. And I believe with this viewpoint of mine, I've been able to convince you, not to convince you, that you need a CMR protocol in your local clinic. Thank you.
Thank you, Harrison. That was super fantastic. We are a little bit tad behind time, but we didn't also quite start exactly on time. We had to give people time to arrive. So there are some questions in chat, and one thing I wanted you to jump off on, Harrison, if you kind of go back to that slide you had, just
Which of
summarizing the let me just see what slide number it is. Just give me 1 second. This is probably slide 20, no, 4. If you
this?
just want to just yeah, 24, slide 24. Just one back. One back. Yes. So if you just want to start off with safety, CMR safety, because there is a obviously a define CMR safety, especially if you're dealing with GAD and also having a moving imaging a moving organ. So can you touch on that, and where does that fall into your phase? Is it the foundation phase where you set that up? Is it the expansion phase where you set that up?
So I believe CMR safety should be at the foundation safe stage. As much as possible, even before you, if not, if it is not CMR, we could basically do it, or you have to do it for other MR imaging I've got for. But then if you are doing CMR specifically, you need to, I think I have a slide for it. I have a slide for it. Yeah, I think so. I think so. Yeah, I do. Okay, this MRI safety is basically the first you need to put into consideration when you are, except Prof, you have other things to say. I know you have a better understanding compared to me, but MRI safety is my number one to do this that has to be included at the foundation stage, not at the extreme end. It has to be at the beginning. You have to put that into consideration because you know the safety that's relates with MRI. Yeah, Prof, you could add some.
Fantastic. Perfect. That's great. Yeah. So there are a couple questions, and I think we probably have just a couple times to a few times to take up those questions. I mean, obviously, most of the comments are obviously they enjoyed the presentation. And Harrison, thank you so much for putting that together. There's a question from Abu Bakr Muhammad asking, um, is there a need to regulate heart rate just like in cardiac CT? I'm not sure if you can
Yeah,
regulate heart rate, but anyways, go
yeah.
ahead,
The good
Harrison.
the, the good thing about cardiac MRI is the system has the capability to regulate itself. Unlike cardiac CT, if the heart rate is too high, you cannot do it. Now, why I said so is because of the ability of the system to carry out both prospective and retrospective gating, if and also having the ability to what they call the peripheral gating. The peripheral gating can help you acquire images. It's not too far. It's not as in city with a very high heart rate, you cannot do beyond 70. But I have seen and I have done CMR even for patients with unusual heart rates, up and down, goes high, comes slow, goes high, comes slow. You are able to do. The most important thing for cardiac imaging is that it works with the patient breathing. And why I said so is because um, if you are able to tell the patient to control their breath, say hold your breath for say 5 seconds or 10 seconds, you will get fantastic imaging. Even with an unusual high heart rate, you will get fantastic imaging that is comparable to what is obtainable in the West, which is fantastic to me. So it's not unlike CT. CT with 70 and above heart rate, you are handicapped. You are not able to do much because you're going to get stepping artifact on the image. But in MRI cardiac, with the ability of the system to carry out both retrospective and prospective gating, you are able to a large extent, we put in negligence the heart rate of the patient or the how would I, if the heart rate is high, we can still do it. If the heart rate is low, we can still do it. And then we are able to also coordinate the breathing sequence of the patient, either manually or with the help of the system. And you can get the fantastic images with that. So that's just for me.
Okay.
It shouldn't be a no-no.
Okay. So that's fantastic. Francis Mensa asked, does cardiac software come standard or it varies from vendor to vendor?
Oh, I don't understand that question, man.
So does the scanners come with the cardiac software? which most of them do, but you have to buy the
Yeah.
license. But I'm going to
Yeah,
let you answer that. And is it standard? Is it standard, or does
yeah,
it
it's
come
standard. It's
depend
standard,
from
but
vendor to vendor? Yeah.
it's standard. It's standard in theory and practice, but the name might be different. The naming might be different, but across in terms of practice, it's standard across board.
Okay. Fantastic. And let's see. Is there any software you recommend? Just I'm putting you on the spot here.
I can recommend a lot of software. First,
Okay, well, put that
you
in
have to
chat.
have the basics. The basics
Okay.
needs to be there. And when I say the basic, we are looking at the morphological and the functional sequences. Fine. Now, if you have the basics, then you could go for the advanced, which are the mappings. The mappings is also the basics, but it is not easily accessible here in the global south, which is understandable. But if you have access to the T1, T2 mapping, fantastic. If you're able to do the morphology, functional, and mapping, you are 70% in your cardiac imaging. The others is just, flow imaging, tagging, and so on, is just an addendum. But if you're able to get the basics and then the mappings, we are good to go.
And just quickly, in terms of software, I just want to make sure we're covering both ends of the question. There is a sequence license, which is what you described, and there is analysis software. Does those analysis software to do some of the analysis, like the Mayo mapping or the Mayo maps that you talked about, do they come standard, or is it something that you have to buy on top of your sequence licenses?
So if your system is already installed, you might need to buy into your system. But if you are about installing your system and you have opportunity to influence the sequences that are to be included, I don't think they will want to bill you for it. So it is a two-way something. If you are about to install, make sure you request for everything. You should be able to run analysis on your good thing with Regions Hospital and fantastic for them. They were able to make inquiry to get, before they install their MRI, they had the ability to make requests for basic and advanced sequences, and the ability to analyze at least, depending when the radiologist comes, sends in their review, which is fine. But if you have already installed your sequence and you want to go back to the vendors to say, I need the ability to analyze cardiac images or I run advanced study, they might want you to buy in. They might want you to buy in, depending on your memorandum of understanding with them.
Okay, fantastic. Just a reminder for everyone, like I said earlier, if you missed it at the beginning, there is a course evaluation. This is how we track your attendance. We do give out certificates. You have to do 6 of 8. There's obviously 8 weeks. Your certificate. I just popped in the chat the link to the evaluation form. So please fill that out. It actually helps us build better courses as we move along. I think we have a couple more minutes for questions. There is one here. I saw one from Victor. Where did he go? Well, let me just go back up here. 1 second. Blah, blah, blah. Victor, saw your question. Oh, yeah. So Victor wants you to give a highlight on volumetric analysis.
I don't understand.
I guess Victor wants you to touch on a little bit more about how you can do volumetric analysis.
Oh, okay. So, Victor, I don't have much experience for volume analysis. But the volume I have, the experience for volume analysis is for the 3D experience. Because when we talk about volumetric analysis, you might do a 4D or a 3D volume imaging. The one I have experience more on is the one you have for the one I showed on the screen. 1 second. Okay, we could do this. I only experienced this other one where you are able to see the first pass artery at McGill University Health Center just once. And unfortunately for me, before I left, I couldn't have another ability to do this. But for this one, it's just a sequence on your scanner. You are able to run, and you should know where you should put your cursor. I think you can put the cursor across the full length of the abdominal, from the thoracic to the abdominal aorta. If you know where to put your cursor across board, you should be able to acquire this. Just a sequence you run on your scanner, and that's all. And I believe also this is a basic sequence on all MRI scanner that has the capability to run cardiac MRI. It's a basic sequence. Compared to this is a little bit advanced, and it has to do with the injection of gadolinium for you to be able to acquire this.
Okay, fantastic. And I'll see if I could drop some links in the chat as well for SCMR from SCMR for some of these questions. There is the CMR Pocket Guide. I put that in there.
Yeah.
I think that's just a quick and dirty way of learning cardiac MRI. I mean, I do brain imaging. That's what I use to quickly pick up on CMR, not that I'm a pro. Okay, so quickly, let's see here. Vivian, I'm hoping it's a Vivian that I know. Hello, Vivian. Is asking a question about repeating images due to artifacts. That's a very important question. If a good
Yeah.
cine imaging has been acquired while you're acquiring your LVOT, cine, and the abandoned antiquary comes up, this is the Vivian that I know. Is there a need to repeat it if we are looking at outflow tracks? Fantastic question, Vivian.
So repeat in cardiac MRI is not like repeat in CT or X-ray. Now, like I said, when I was practicing in Nigeria, there are some artifacts that are negligible to me. But when I began to practice at the McGill University Health Center, I realized that those artifacts that are negligible to me are not negligible out there because they are part of my evaluation. So take, for instance, the myocardium, and then you have an artifact, a band artifact running in between like this. When I was practicing, I could basically just underrate it. Oh my God, I've gotten a good signing imaging, which is fine. But then, over the since it is part of my evaluation, I realized that no, I cannot pass this image. So a repeat of this kind that doesn't take you less than about 30 seconds to acquire or say 15 seconds to acquire, please repeat. And if, for instance, you do LVOT is basically like 15 seconds. So if you don't get a good LVOT that shows you the upload track and then the muscles surrounding it, you should repeat it. It does not take radiation. It does not take time. You just need to know how to plan yourself. If you already have a very good localizer, why are you killing yourself not to repeat this? Repeat it and grab a piece of and have your peace of mind. One thing I learned from Professor Friedrich Group, sorry, I have to use them as an example, is especially for before we run the mollies, which is the T1, T2 mappings. The T1, T2 mappings are artifact sensitive. Artifact sensitive, yeah. In which case, you have to do a scout before you do the actual mappings. So when you do the scout and you see artifact on your scout, you don't go ahead and do your actual mappings. You have to repeat the scout and be very sure that you get your imaging so that when you do your actual mappings, you are good to go. If you pass an artifact prone or artifact disoriented images to the radiologist, it will be sent back and you will get a query for it. That level of excellence is what we should see in Africa. And this is the Vivian I know. Vivian is a top-notch lady. She's already practicing internationally, and she will understand that you cannot let that patient go, no matter how small. You have to try as much as possible to get the best imaging during your scan. Because as soon as the patient comes out, taking the patient in again is a tug of war. Yeah, Prof. Prof, are you there? Oh, I think I'm done. Dr. Nosike, am I good?
Yes, you're good, Harrison. Just a minute. Dr. Nazudo is just going to
Oh,
come
sorry,
on.
I'm talking. I'm unmuted. Sorry. Um, so Harrison, I was actually saying that this ties into the first question you asked, which is 3T CMR has more artifacts than 1.5T. Why is that?
Yeah. I mean, from experience, not by papers now. When we work with the 3T MRI machine, it is more prone. So when I hear people say more prone to artifact, I didn't really understand it until I experienced it myself, and I realized that the proneness is much more compared to 1.5. I don't know for now. Maybe vendors are now working on having to do as much as possible to reduce the artifact. But then that being said, 3T more prone. So for Vivian that has an international experience, she might be working with a 3T or a 7T MRI, in which case
7T? Okay.
she should be expecting more artifact. And then, you know,
Yeah, so Harrison, let me just quickly answer that. So the people think the higher you go in field strength, the fantastic the images are, which is kind of true because they have a higher signal to noise ratio. But
Yeah.
that also comes. MR is a yin yang. It's there's no free lunch, as people say in MRI. There is always a trade off. So the higher you go in field strength, even up to 70, because you can do 70 cardiac MRI,
Hmm.
there is obviously this improvement in spatial resolution, but you have to have a lot of power that you push into your gradient and RF. And those also create its own issues. One of the issues is the higher field strength. You also have susceptibility effects. You have field inhomogeneity because you don't have a massive field you're trying to get to be homogeneous to create that very nice images. And so you also have shorter T2 effects because of the greater B naught or the greater infield inhomogeneity. So all of that will contribute to images appearing and obviously looking a little bit more with artifacts and noise compared to 1.5T. That's
Yeah.
actually one of the selling features of 0.55T, like one of these new low field scanners that are coming out. These scanners are really great for cardiac imaging because you don't even have a lot of this susceptibility artifacts, especially when you're trying to do some of this dark blood imaging or cine imaging. You don't get a lot of this artifact. So it's not always the higher you go, it's better. In some cases, the higher you go comes with its own baggages. And one of those baggages is field inhomogeneity. Okay. So Harrison, I think we could take a couple more and maybe call it a day. Again, I'm going to ask people to remember to do their weekly evaluation. Harrison, there is a question about blah blah blah. I'm requesting for sequences exactly needed for each indication. Where can we get it? India, I will ask you to kindly do your evaluation because there's a question for that. Your email is captured because we need to capture that to get you your certificate. We'll be able to respond back to you guys the list of indications. I'll say do your evaluations and we'll be able to get back to everybody on that. One more thing, Francis is asking, Francois, sorry, is asking, I use Siemens Scan 1.5. I'm told by the vendor that the cardiac software has been bought, but does not come standard. Yeah, cardiac sequences, most of them don't come standard. You have to negotiate. It doesn't matter if it's cardiac, it doesn't matter if it's for brain. Any indication when you buy a scanner, you buy your sequences and you also buy your analysis software. And most of them are packaged together when you get in the system. Harrison, I don't know if you want to add anything to that.
No. You said it all.
Okay. Star said, thank you, Harrison, for your presentation. Is it necessary to repeat sequences? I think you've already said that. If artifacts are not within the area of interest,
Within the area of, if it's not on the art, then we are not concerned. But as long as it's on the art muscle, fine. You have to repeat.
Right. Perfect. Professor Usman Bello, the videos are recorded, the courses are all recorded. So we have 6 more to go. They're all recorded and we're going to release them together as a package at the end of the course. So please, like I said, stick around for that. I think we're getting to the end. I just want to mention a couple of things beyond the evaluation. There is, and Harrison mentioned this, the swim cardiac MRI training program we did for radiographers. I would recommend that people go back and revisit that. I've put the links in the chat. It is a well-tailored CMR program that's tailored to the indications that we tend to find typically in Africa and Southeast Asia. They're very conceptual, lots of YouTube videos, very hands-on. We did a live scan with Siemens, so there is a protocol there that actually has somebody in the scanning. You watch them as they build the protocol and also how they set up and prepare and plan each of those sequences. I recommend people visit that. Again, the course evaluation can help us. We can pop in more questions in there in case you miss it. If you want us to send a list of sequences that somebody asked, please put that in the course evaluation. We'll be able to respond back to you by email. I think, Harrison, we might call it a day. I'm just going through the screens. I don't see anything. So I'm going to pop it back to Dr. Anosike, who is our convener, to just kind of wrap us up and introduce next week's course.
Thank you very much, Prof. Uduna. It's been a wonderful evening, and once more, I don't take it for granted that people leave their Saturdays to come out Saturday evening when you could be out doing other things to come and get this knowledge from the experts that are speaking. So Harrison has done a wonderful job today covering a lot of areas. and hopefully giving some people food for thought and also challenging them to do more. And all of the resources we've given here, if you stick with us for the 6 to 8 weeks, or for the 8 weeks this course will run, there will be a lot more resources shared, and a lot of this is open source and not for a fee as well. So thank you very much for sharing your evening with us. Next session, I'm just going to bring it up. Sorry, Prof. Uduna, can you please share that slide just to see the next?
Yep, I could do that quickly. 1 second. Let's just do that here. Screen share. Okay, oops. Sorry, I'm just trying to find my Zoom screen share, which just disappeared right here. Screen share and that one. Just 1 second. Okay.
Okay, so just going to get, so the next talk is going to be on the 25th of April to be done by Dr. Ofong, and it's going to be CMR in ischemic cardiomyopathy, viability assessment. So that's going to be another interesting session, and we look forward to seeing as many of you as are here, and also invite your friends and colleagues who may be interested in these topics. We look forward to next week to be able to enjoy that. So without keeping you any longer, I'd like to thank you for coming today, and I wish you a good weekend ahead. Any questions that haven't been answered in this session, you will get responses in your email if you feel we haven't answered your question. When you've completed the survey, we've got your email contact, and we'll be able to provide more information or more clarity if you don't already have it. Okay, thank you so much.
Thank you. Well done, Harrison. Thank you, everyone.
Thank you, everybody.
Thank you.